Hello, everyone. Thank you for joining us today for our special 4-part webinar series on managing hypertension and diabetes by mastering health IT. Today's presenters are Bruce Mackey and Vicki Gallaty. My name is Liz Jones, and I'm today's moderator. Before we begin, I have a few housekeeping items to touch on. We'll be keeping the phone lines on mute during today's presentation. If you have a question, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we're unable to get to all of the questions, we will email you directly with an answer following the broadcast. We'll also be posting a recording of today's presentation on our website on mceda.org, and a copy of today's slides are available there now. Alterum Institute is a nonprofit organization with nearly 70 years of experience researching, developing, and implementing solutions that serve the public good by solving complex systems problems to improve human health. Our staff members are leaders in identifying, understanding, and solving critical systems issues that impact health and healthcare. From designing and developing health information technology systems to working with healthcare providers to foster clinical quality improvement, we are widely acknowledged by the federal government, the state of Michigan, as well as the private sector, and a valued, pragmatic, and objective partner of utmost competence and integrity. With over 400 employees, we have offices in D.C., Virginia, Maryland, Maine, and our corporate headquarters in Ann Arbor. Housed within Alterum, we are MCEDA, the Michigan Center for Effective IT Adoption. Originally born out of the HITECH Act, we're more specifically ARRA, MCEDA is Michigan's regional extension center, tasked with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted over 5,700 providers across Michigan, impacting 1.6 million patients annually. 1 out of 4 Michigan providers paid a meaningful use incentive payment did so under MCEDA's expert guidance. Ranked as the fifth largest REC out of a national network of 62, we are now also funded by the state of Michigan to assist providers in the Medicaid Meaningful Use Program. Our services are highly subsidized for qualified providers. Our health IT services include meaningful use support, any stage and year. Security risk assessment, which is an embedded service within our meaningful use support, but if providers have meaningful use handled and only need assistance with SRA, we offer it as a standalone service that can be offered separately. Targeted process optimization, or TPO, takes a stripped-down version of lean principles and applies it to any clinical or operational practice improvement initiative. No matter what you need help with improving in your practice or clinic, we have experts on hand who can assist. Finally, attestation and audit preparation. If you're getting ready to attest to meaningful use and need some peace of mind that you've crossed all the T's and dotted all the I's, or if you're one of many folks who have been selected for a meaningful use audit and need assistance responding, we're here to help. In today's presentation, we'll take a few moments to set the stage discussing some of the alarming national and state statistics regarding hypertension and diabetes. From there, we'll move on to the heart of today's materials, discussing how you can leverage your health IT to identify diagnosed and undiagnosed patients who need help, engage patients as well as healthcare teams, monitor patient symptoms and leading indicators, analyze patient and population health improvements, and improve the health of your patients. Finally, we'll have some time at the end for some Q&A. With that, I'd like to turn things over to Bruce Mackey, who will begin by briefly discussing diabetes and hypertension in America.
Thanks, Liz. No one can argue against heart disease and stroke being immense issues in the United States. They are currently the first and fourth leading causes of death in the U.S. More than 2 million heart attacks and strokes happen in the United States each year, leading to over 800,000 deaths. They are the leading cause of preventable death in people under 65 years of age. Approximately 1 out of every $6 spent on health care in the U.S. is spent on treating victims of heart disease and stroke, and they are the greatest contributors to racial disparities in life expectancy. Approximately 82% of hypertensive adults are aware of their condition, and 75% of them are on antihypertensive medication, yet only 53% have their condition controlled to target levels. A staggering number, approximately 16% of Michigan's adult population have uncontrolled hypertension. Taking a look at the numbers around diabetes, a staggering 29.1 million people, or 9.3% of the population, have diabetes. That is nearly 1 in 10. Diabetes was the 7th leading cause of death in the U.S. in 2010. It was listed as the primary cause of kidney failure in 44% of all new cases in 2011. And in 2011, an estimated 10% of Michigan adults were diagnosed with diabetes. An additional 250,000 Michigan residents are thought to have undiagnosed diabetes, and we're here today to attempt to put a dent in those terrible numbers. So what's being done in our country to battle hypertension and diabetes? There's a tremendous amount of excellent work being done on a national and state level to battle these diseases, many of them attempting to bring standardization to the way they're treated. 3 examples of the many initiatives out there are the Joint National Committee, or JNC, have their 2014 evidence-based guidelines for the management of high blood pressure in adults. As a side note, where appropriate, we'll be discussing things from the standpoint of JNC 7. While JNC 8 has recently been released, most of the EHRs have not yet incorporated these new guidelines. As such, since your Health IT speaks in terms of JNC 7, we will too. The American Association of Clinical Endocrinologists have issued their comprehensive diabetes management algorithm, and the American Diabetes Association have issued their standards of medical care in diabetes. The Million Hearts Initiative, co-led by the CDC and CMS, focuses, coordinates, and enhances cardiovascular disease prevention activities across the public and private sectors in an unprecedented effort to prevent 1 million heart attacks and strokes by 2017. With partners spanning federal and state agencies, as well as many private organizations, Million Hearts aims to prevent heart disease and stroke by improving access to effective care, improving the quality of care, focusing clinical attention on the prevention of heart attack and stroke, activating the public to lead a heart-healthy lifestyle, and improving the prescription and adherence to appropriate medications. Recent years have seen a steady shift to a new paradigm called the chronic care model, a visual guide to the comprehensive, integrated reorganization of care delivery needed to improve important patient outcomes by focusing on essential elements such as the community and health system, self-management support, delivery system design, decision support, and clinical information systems. What we're discussing today is essentially this chronic care model through the eyes of health information technology. Remember this list of elements, and you'll see each one reflected at different times in today's presentation. Right now, I'd like to take a few moments to focus on one side of productive interaction, the prepared, proactive practice team. Leveraging your Health IT to improve the health of your hypertensive and diabetic patients takes a huge team effort. Transforming your practice into a model of team-based care is essential to improving outcomes. So let's take a few moments to discuss the concept of the team. I was a practice manager for close to 10 years, so like all of you, I can attest to the fact that clinical settings have many, many moving parts. Most days feel like a barely controlled chaos where everyone is doing everything they can to tread water, survive the day, and hopefully not miss something critical. This frantic pace makes it very challenging to work together, focusing on the key areas of effective communication and coordination, sticking to evidence-based guidelines, and structured follow-up and monitoring, all while actively engaging patients and team members. It's vital, however, that as we discuss various activities today, that you make it a priority to include a wide range of team members into this model of leveraging your Health IT. As mentioned, successfully leveraging your technology to improve the health of your diabetic and hypertensive patients is a team effort. But what makes a good team? According to the best-selling book, The 5 Dysfunctions of a Team, successful teams trust each other to fulfill their responsibilities, communicate effectively and critically, are committed to achieving the team's goals, establish accountability to meet their goals, and focus on results, which in this context are quality health outcomes. Though certainly easier said than done, it's difficult to argue with the fact that if you have a team that exhibits these 5 elements, that barely controlled chaos in the practice just simply works. And not only does it works exceptionally well. With the importance of team-based care in mind, I'd like to introduce you to the model at the heart of today's presentation, something we're calling the Health IT Patient Management Model. In a nutshell, it is a PDSA, or Plan, Do, Study, Act cycle that leverages health IT to identify, engage, monitor, analyze, and improve the health of your diabetic and hypertensive patients. The rest of today's presentation focuses on each one of these areas. We'll start by discussing how you can leverage your health IT to identify hypertensive and diabetic patients. A critical element to leveraging health IT is the concept of the structured data field. Within an EHR, nearly every data point has a specific field designed to hold that information. If you and your team are not maximizing the use of structured data fields and are instead manually typing everything into the patient's progress note, it's quite literally a case of garbage in, garbage out. Using structured data fields to capture risk factors and comorbidities such as demographics, tobacco use, and family history, entering and updating the problem list, and capturing other causes that may be affecting the patient's health allows you to effectively report on and analyze the data. If everything is locked inside a progress note, there is little that can be done to use that data to improve outcomes. As odd as this sounds, one of the often overlooked elements needed to properly identify hypertension is capturing accurate blood pressure readings. It's basic, and no doubt many of your staff will roll their eyes when you let them know about it, but you would do well to take the time to hold a blood pressure in service to ensure staff is properly trained and everyone is taking blood pressure readings in the same accurate way. You may be surprised to find how many of your staff need coaching in this very basic skill. Over time, poor habits form and skills drift. To identify hypertension and effectively manage these patients, you have to be able to rely on these readings. To effectively leverage your health IT, you need your lab results in as structured data. A lab interface is, of course, the best way to accomplish this, but if that's not possible, manually key in those lab values. Most, unfortunately not all, EHRs will allow you to manually enter lab results in the field designed to hold this data. Remember, if it's not structured data, you cannot easily analyze and report on the results. Interoperability, or the electronic exchange of information between health IT systems, is at the core of the Meaningful Use program and is a vital component needed to identify your hypertensive and diabetic patients. To get a complete picture of the patient, you also need to know what other healthcare providers know. To do this effectively and efficiently, you need to be able to exchange patient information using your EHR's embedded direct or peer-to-peer technology, or better yet, use one of several health information exchanges, or HIEs, to act as a medium in the data exchange. A very basic tool in the charge to properly identify patients is your EHR's ability to query the database to generate sublists of your patients. If you're participating in the Meaningful Use program, you're no doubt already using your EHR to generate patient lists. But what patient lists are you generating? And more importantly, are you doing anything with those lists? You can use this basic functionality to have your system tell you who your diabetic and hypertensive patients are. From there, you can use those lists to ensure patients are being treated properly and effectively. In a few minutes, we'll also show you how to creatively use the same basic functionality to help you identify undiagnosed patients. Clinical Decision Support, or CDS, provides clinicians, staff, patients, or other individuals with knowledge and person-specific information intelligently filtered and presented at appropriate times to enhance health and healthcare. CDS encompasses a wide variety of tools to enhance decision-making in the clinical workflow and is a key component that should be leveraged to help teams identify hypertensive and diabetic patients. When used well, CDS can be used to ensure proper screening tests are completed for targeted patient populations, and alerts and reminders can be enabled to identify at-risk patients or to alert team members to patients who require additional follow-up. A very basic form of CDS involves enabling alerts to identify abnormal labs, assessment results, and vitals, but should also be used to create order sets which ensure a complete workflow is followed every time. When used to its fullest extent, CDS can and should be an essential part of the toolkit used to help you identify your target patients. And since CDS is not only a tool for identifying patients, we'll touch on it again in the next section on monitoring. If all team members are properly using structured data fields, you can use the wealth of data already in your patient database to help you find undiagnosed and at-risk patients. Imagine the impact you can have in the health of your patients if you can massage the data you've already collected to help you find undiagnosed patients. If they're undiagnosed, they're obviously not receiving the care they need. Mine your existing patient data and you'll likely find patients in need. A basic way to do this is through simple trending of blood pressure readings, looking for elevated BPs without a corresponding diagnosis. You can also take a look at your at-risk population by examining additional risk factors already on record. Have you adequately screened all patients for known associated risk factors to see if they're diabetic or hypertensive? We'll focus next on a protocol you can incorporate today to find undiagnosed diabetic patients by examining the relationship between diagnosis, medications, and lab results. This is a powerful workflow that could have a huge impact in your practice, and it simply involves analyzing and comparing the patient data you've already collected. This protocol was developed from a study published last year in the Canadian Medical Association Journal. Although it appeared in a Canadian medical journal, the researchers looked at 11.5 million U.S. primary care records, comparing the relationships between diagnosis, medications, and labs. Through this analysis, they identified a list of over 63,000 potential undiagnosed diabetics. The next slide summarizes the steps they took to extract this list of potential undiagnosed patients. By following this same protocol in your practice, you'll likely find some undiagnosed diabetics in your own patient panel. Looking at the top of this figure, you'll see the initial starting population of 11.5 million records. To the left of that, they sectioned off the records that indicated a diagnosis of diabetes or the use of diabetic medications. Interestingly, you can see that there were 422,000 patients who were on diabetic medication with no diagnosis of diabetes. So even with this very basic analysis, they likely uncovered patients who are being treated for diabetes without having an active diagnosis in the chart. Of the 10.4 million records left, they then sectioned off patients with gestational diabetes, as well as those with a diagnosis of prediabetes or impaired glucose tolerance, leaving them with approximately 10.3 million records. Although not a part of their protocol, since it involves further testing and not just examining the existing data, the pre-diabetic and impaired glucose tolerance patients should also be re-examined to determine how many of them have crossed over to diabetes since this initial diagnosis. It's likely that some of them should now be diagnosed as diabetic. From there, the researchers divided these remaining records into two groups, those with fewer than 2 abnormal glucose levels on record, and those with 2 or more abnormal glucose levels. Those with 2 or more abnormal glucose levels on record are easy. Based on the criteria, these 40,359 patients are likely undiagnosed diabetics. The other remaining group of patients with fewer than 2 abnormal glucose levels on record was analyzed a step further, removing records with no abnormal A1C results. This removed another 10.2 million records. The remaining 23,000 plus records indicated at least one abnormal A1C result, meaning they too could be undiagnosed diabetics based on the criteria. Adding the two remaining groups of records together, they identified 63,620 potentially undiagnosed diabetic patients because there is record of either an abnormal A1C on file or abnormal glucose levels. Since the researchers were dealing with de-identified patient data, that's where their analysis stopped. Taking it to the next logical step, once you follow this protocol in your own office, you would likely recall these patients and conduct further testing to determine if they are actually diabetic. You'll no doubt find that the majority of them truly are. With this new accurate diagnosis, these patients can now receive the care they need. These are powerful results by simply analyzing the data you already have at your fingertips. Now we'll move on to ways you can leverage your health IT to monitor your patients. One of the most basic ways to monitor the care of your diabetic and hypertensive patients is through the tracking and trending of associated clinical quality measures, or CQMs. Reporting on CQMs is a requirement of various programs like Meaningful Use, PQRS, and ACOs. There are several CQMs related to diabetes and hypertension, but the two most heavily promoted, and subsequently the two you're heavily encouraged to use, are NQF-18, controlling high blood pressure, which gives you the percentage of hypertensive patients who have their blood pressure under control, and NQF-59, comprehensive diabetes care, which looks to identify diabetic patients who have poorly controlled A1C levels or no recent results on record. Analyzing these CQMs will help you to determine how effective you've been in managing these disease states and improving outcomes. If you're doing well, you'll have a high or at least increasing percentage on NQF-18, and you'll have a low or at least decreasing percentage on NQF-59. Another health IT tool at your disposal for monitoring your patients is through the use of an electronic diabetes registry. Though currently underutilized in the U.S., use of a diabetes registry is an initial step to controlling diabetes and is a basic requirement for structured proactive care. Studies have shown that use of diabetic registries significantly improve outcomes. These identified patients are easier to monitor once on the registry, and once diagnosed and registered, have a significantly higher level of achievement of several quality of care indicators used to monitor patient health. If your providers are in stage 2 of meaningful use, using a diabetes registry satisfies the specialized registry menu measure. We discussed clinical decision support under identification, but CDS should also be used as a powerful tool for monitoring your patients. For instance, alerting the provider or clinical staff to vital information regarding the ongoing treatment of patients already diagnosed. When CDS is applied effectively, it increases quality of care, enhances health outcomes, helps to avoid errors and adverse events, improves efficiency, reduces costs, and boosts provider and patient satisfaction. CDS is not intended to replace clinician judgment, but rather to provide a tool to assist care team members in making timely, informed, and higher quality decisions. CDS is often an integrated part of the provider's EHR system, but may also present in a variety of other mechanisms, including but not limited to pharmacy systems, patients' personal health records, or PHRs, and patient portals provided by the practice. Some providers use certified EHR technology to drive, trigger, and receive CDS in an external system, for example, sending data to a registry. There is no definitive or comprehensive list of what can constitute CDS. ONC and CMS broadly interpret CDS in the 2012 Meaningful Use Final Rule, which allows a wide variety of innovative and effective decision support tools available to providers. And as a means of monitoring, you can use your EHR to track and document adherence to lifestyle modifications by indicating if CV and CBG logs and dietary or activity journals were completed. In order to monitor your hypertensive patients, you can use graphs and grids within your EHR to identify and track trends in your now standardized readings. With lab results all being entered as structured data, you can also trend these results to understand changes. When referrals are initiated through your EHR, and especially if and when the data flow is bidirectional, you can use this advanced functionality to ensure your patients are compliant, as well as electronically receive results from the next provider of care. With the advanced functionality of your EHR and the wealth of structured data being entered into the patient's chart, you can enable tools to monitor your patient's compliance with prescribed drug treatments, as well as effectively analyze the tolerance or effectiveness of prescribed meds and dosages, making adjustments as needed to ensure quality outcomes. With that, I'd like to turn things over to Vicki, who will start by discussing how you can leverage your health IT to engage not only your patients, but your entire healthcare team.
Thank you, Bruce. An integral member of the healthcare team is the patient. Productive interactions with the patient aids in the improvement of patient outcomes. A fully engaged patient allows providers to treat patients in a timelier manner. In the chronic care model, communication between the patient and practice team is key to informing and engaging the patient. As healthcare delivery is moving toward team-based care, the primary care provider acts as the care manager. Technology has eased the communication among the team members, including the patient. In the following slides, we will discuss the engagement of all members within the team and its benefits. Health IT and EHR have enormous potential to engage patients. When used effectively, Health IT and EHR can engage patients by fostering collaboration and communication between patients and providers, enabling electronic management of appointment schedules, facilitating quick and easy communication between patients and providers, giving providers a vehicle for convenient outreach to patients following office visits, hospital stays, appointment reminders, offering patient access to full and accurate information about their care, and promoting chronic condition self-management. EHR has the unique ability to provide health information to its patients. Individuals require access to health information in order to better understand their own current care and treatment, as well as that of family members in their care. To coordinate care and reduce duplication of services among multiple care providers, maintain a personal longitudinal health record that tracks their health conditions and care provided over time, and health information must be timely, accessible, accurate, and understandable in order for it to be beneficial and useful to consumers. However, whether it is provided on paper printouts or through technologies such as web portals, portable media, mobile devices,
the consumer and patient engagement must be supported through up-to-date organizational policies and practices that address patient access and availability and reflect the requirements for consumer engagement. Continuous education of patients, providers, and other healthcare professionals in their respective roles relative to health information to support engagement, and advocating for consumer-patient engagement through public policy and standards implementation. One of the hardest things with adapting new processes or lifestyle is cultural change. People naturally tend to avoid the uncertainty of change. Patient engagement needs to be a cultural commitment to improving clinical processes. Technology should complement the process of change. The change should start within the practice. Look at ways that are unique to the healthcare arena on how to engage patients. You need to build trust with patients through frequent communication and education. Acknowledge barriers and do not dismiss patient concerns. Help the patient create small, measurable goals and reach out to patients to get them involved with their own treatment and care. In addition to engaging the patient, the goal is also to engage the clinical staff. Engaged clinical staff can be the loudest advocates for the utilization of IT tools to increase patient care outcomes. To ensure that all staff is engaged, can start with assessing that the staff are in their current roles and redefine them. Ensure each staff member is operating at the top of their scope. Standardize the care through cross-training of all office staff, utilizing protocols and standing orders, and incorporate all the tools into the clinical documentation in the EHR. You can utilize technology to reduce workloads. For example, directing patients to submit prescription refills requests at the pharmacy or through patient requests through the patient portal can free up time of the clinical and office staff to be used in other capacities. You can also exchange patient information to other providers that are actively involved in the patient's care, utilizing HIT functionalities to communicate concerns and relevant information, and be sure to provide a summary of care document to each provider involved. Despite a patient's desire for health restoration and good intentions, patients often struggle with adapting to the lifestyle changes required. Potential barriers to patient engagement and compliance with treatment exist, and they need to be understood by the healthcare team in order to overcome them. There may be a lack of resources and tools. Finances can also be a huge factor, especially when related to competing priorities. For example, a patient may have to choose between paying for food or paying for their medication. There may also be emotional reasons, such as the inability to adapt to a lifestyle modification due to cultural reasons or not liking how it makes them feel. The key is to empower the patient with access to resources and to be an active participant in their own care. Whether it is addressing emotional concerns through community resources, such as peer-to-peer education or support group, or even providing a printout from within the EHR of local programs that can assist the patient with obtaining medications or transportation services that are free or at a discounted rate. A healthcare team must also understand that information technology barriers may exist. These can include the lack of interoperability in health information technology systems. While the hospital may be on one EHR system and their EHR-specific portal, your doctor's office could be on a completely different EHR system with a different patient portal. Another barrier may be the advanced level of complexity related to the continuing of care across all disciplines. This complexity may be hard to identify and carry over from provider to provider. In addition, double documentation is required sometimes for compliance and incentive programs, and can be burdensome and raise the questions about the need for certain documentation. There can also be a lack of resources available to provide to patients from within the EHR system that are local and relevant to the provider's geographical area. And lastly, the charting regarding patients' concerns with treatment and/or care plan may not cross over to another provider's EHR record. While many healthcare organizations have begun to routinely provide access to lab test results, medication lists, and visit summaries through patient portals, relatively few provide unfettered access to the notes and other documents in the medical record written by physicians and other providers. There are many patient engagement solutions that may be available to help overcome these barriers. The first solution is related to patient outreach. During the patient visit, utilize the health maintenance model, which can provide patients alerts and reminders from within the EHR to identify for gaps in care. However, after patients leave the practice, the engagement must continue to be reinforced. You must develop an action plan that addresses patient goals, as well as the patient's motivation to change and confidence in achieving these goals. Scheduled outreach after the office visit affords the patient an opportunity to ask questions and discuss issues they may have had in trying to meet their new goals, offer support and encouragement, and leverage practice-based resources to maintain information consistency to the patient. One great tool that can be used to facilitate communication between the patient, provider, and care team is through the patient portal. The patient portal can provide secure messaging, direct requests, access to the request, results, education, and key information about their own health. It can provide 24 hours a day, 7 days a week access to the patient's information from any computer, tablet, or smartphone with internet access. However, just making a portal available to patients will not ensure that they will use it. The portal must be engaging and user-friendly and must support patient-centered outcomes. The portal also must be integrated into clinical encounters so that the care team uses it to convey information, communicate with patients, and support self-care and decision-making as indicated. Practices have been used their portals to successfully serve a wide range of patients, including those who are older, have lower incomes, or are chronically ill. Patients are likely to use a portal when it is recommended by their providers and has the functionality that supports patient activation. Portal training and technical support also will help patients to make the most of its tools and services. A valuable benefit to the implementation of EHR patient portals is their ability to conveniently provide education to patients. Many EHRs have robust databases of patient education resources directly available. If your EHR does not have these features built in, it may be possible to obtain them from third-party vendors. Educational resources vary in purpose and format, but often fall into the categories of decision aids, self-management tools, mobile device applications, internet-based resources, and community resources. It is expected that an increasing percent of clinically relevant data will be collected outside clinical settings in the coming years. This highlights the demand patients have for medical information. Providing them with quality education through the EHR allows providers to set the stage for framing patients' conditions and plans of care while empowering patients to make their informed decisions based on accurate information. To sum it all up, patient engagement is the most effective when the entire team is involved. Engaged patients experience better health outcomes, and electronic health records, patient portals, and educational resources can improve patient engagement. Now we will move on to leveraging health IT to analyze and improve. Effective data management is key to performance improvement. Collecting, analyzing, interpreting, and acting on data for specific performance measures allows you to identify gaps in care, to make corrective adjustments, and to track outcomes. In order to have effective analysis of data, we must begin at the planning stages of data collection. We must ask ourselves 4 fundamental questions. Why are we collecting the data? Who will collect the data? What data will be collected? And how will the data be collected? For successful data collection, the process of data collection needs to be easy. Clinical data is extracted from a variety of sources, including electronic health records, information exchanges, disease registries, and even personal health devices and direct patient surveys. Data that needs to be collected for quality measures should be built in as seamlessly as possible into user workflows. Users should also be aware of the data collection process and taught how to enter the data correctly. Examining clinical data completes a 360-degree view, enabling providers to analyze their patient populations, understand which individuals need the most help, and proactively reach out to give them the care they need. When intelligently applied, clinical analytics help not only support a clinic's bottom line, but also improve patient outcomes. There are many sources available to pull raw data to use in identifying and monitoring patients. These include the patient and their family, EHR data, patient registries, and the summary of care document from another provider. The key is to record all the collected raw data and chart them in the structured fields in electronic health record. When charted in the correct data fields, the data can easily be pulled and run to produce useful reports. Some great reports that can be run using this raw data include a report to identify missing labs, or a patient list generated to reach out to a patient with similar diagnosis, or even reports showing the amount of patients enrolled in actually utilizing the portal. Data analysis is taking raw data and converting it into useful information for decision making. In other words, taking the raw data collected and asking, what does this mean? Can this be used to trend blood pressures or identify at-risk populations? Absolutely. It can identify opportunities for improvement. The model for improvement, developed by Associate in Process Improvement, is a simple yet powerful tool for accelerating improvement. The model has two parts. 3 fundamental questions. What are we trying to accomplish? How will we know a change is an improvement? And what changes can we make that will result in improvement? These questions aid in the setting of aims, establishing of measures, and selecting the change to be implemented. The second part involves the Plan, Do, Study, Act, PDSA cycle to guide the test of a change to determine if the change is an improvement. There are many reasons to test change. These include to increase your belief that the change will result in improvement, to decide which of several proposed changes will lead to the desired improvement, to evaluate how much improvement can be expected from the change, to decide whether the proposed change will work in the actual environment of interest, to decide which combinations of changes will have the desired effects on the important measures of quality, to evaluate costs, social impact, and side effects from a proposed change, and lastly, to minimize resistance upon implementation. As previously stated, the Plan, Do, Study, Act, PDSA cycle, is shorthand for testing a change by planning it, trying it, observing the results, and acting what is learned. This is the scientific method used for action-oriented learning. In summary, there are many ways to help analyze and improve the health of your patients. The final products of some of these processes of improvement can include the creation and updating of practice policies and protocols, creating and updating order sets, incorporating logarithms or clinical pathways for treatment, and monitoring progress toward goals.
Thanks, Vicki. As you've just heard, there are many ways that health IT can be leveraged to identify, monitor, engage, and improve the health of your patients. Making the most of your technology means improving the identification of patients, improving the quality and convenience of patient care, increasing patient engagement, improving the accuracy and diagnoses of, and most importantly, health outcomes, improving care coordination, and increasing practice efficiencies and cost savings. In short, healthcare teams should be leveraging the many aspects of health information technology to manage their hypertensive and diabetic patients. Failing to capitalize on the many ways health IT can be used means not maximizing your return on investment. Healthcare teams owe it to their patients and themselves to ensure they're making the most of the available technology to improve outcomes. With that, we'd like to thank you for your time today and to answer any questions you may have regarding the materials we just covered. But before we do, we'd like to take a minute to briefly explain the additional sessions in this series and to encourage you to participate. Today's presentation was a comprehensive look at how you can leverage your health IT to improve patient outcomes, but given the possibilities and time constraints, we could only provide an overview. The next 3 parts of this series take a deeper dive into various sections of today's material and will allow us to provide you with more information as well as introduce and distribute various tools we've developed and collected to aid you and your team in leveraging your health IT. Examples of tools available in these next sessions include protocols for identifying undiagnosed patients, a tool for promoting patient self-monitoring of blood pressure, and a guide for implementing team-based care, as well as several others. These additional sessions in the series will focus on patient identification, followed by one on engaging and monitoring patients, and finally one focused on analyzing data and improving outcomes. If you're on our mailing list, you'll receive notice of these upcoming sessions, or you can check back on our website at mceta.org for registration details. We hope to see you there. All right, let's get to your questions.